Good morning, good afternoon, good evening to everyone. Welcome to the ISGyP Live Journal Club. Our theme today is Vulvar and Vaginal Pathology. I'm Becca Wolsky, speaking to you from the University of Colorado, co-moderating with Natalie Benet from the Cleveland Clinic. Before we get to our programming, I'll draw your attention to the upcoming live ISGyP Live events. So a podcast will drop August 24th at noon. That will be Dr. Kelly Devereaux speaking on routine molecular subtyping of endometrial carcinoma. And of course, that'll be available for listening thereafter. Also on August 24th at noon Eastern Time, Dr. Jenny Bennett will be moderating the interesting case presentations by trainees or early career pathologists. So be sure and try to tune into all of those or watch them later. A reminder that the ISGyP Journal Club is global, with the Western Hemisphere occurring the third Wednesday of every other month at 12 noon Eastern Time, and the Eastern Hemisphere occurring the third Thursday of the alternating months at 12 Melbourne time. Here's the schedule of our topics through 2022. So the next will be in September on uterine mesenchymal lesions. And some exciting news, Dr. Benet and I are happy to welcome a new future co-moderator for the Western Hemisphere Journal Club, Dr. Ian Hageman from WashU. He's an associate professor there, and he is one of our panelists on today as well. So he'll begin moderating more towards the end of 2022 or early 2023, and welcome, Dr. Hageman. For those of you interested in participating, we encourage you to contact us. We do offer detailed mentorship leading up to these presentations. So if you're interested, our emails are below on this slide, and please reach out to one of us. Now to the main event. So our three presenters today are Dr. Paula Toro Castano, a PGY2 in pathology at the Cleveland Clinic. Dr. Kamille Tuma completed her fellowship in the Salomão Zoppi Lab in Sao Paulo, Brazil in March 2022, and is now a newly practicing surgical pathologist in the Laboratório Diagnóstico da América in Brasília, Brazil. And finally, Dr. Anusha Vemuri is a PGY3 pathology resident at the University of Chicago, and I want to thank all three of you for your time and dedication. The articles to be presented are listed here, and I'll let them each read the title at the start of their talks. The objectives for the Journal Club are listed here, including engaging trainees and early pathologists, offering opportunities for presenting and moderating to members from all parts of the globe, providing mentorship, and engaging future leaders from around the world. So that's all of you in the audience. Here's the outline and assignment that we ask of each presenter. And our schedule today, once I stop sharing my screen, will be Dr. Toro Castano first, then Dr. Tuma, and finally Dr. Vemuri, and we'll wrap up in questions and be done by the hour. As a reminder, we are in a webinar format, so please use the dedicated question and answer or Q&A button for questions to the presenters and to the moderators. You'll also have the option to upvote or prioritize questions. And then please use the chat. Feel free to say hello to everyone and let everyone know where you are in the world. Thank you for joining us. And I'm going to stop sharing my screen now. So Dr. Toro Castano, if you want to share your screen.
Good afternoon, everybody, and thank you so much for joining us today. Thank you so much, Dr. Wolsky and Dr. Benet, for this opportunity. And first of all, I want to confirm that you can see my screen and that you can hear me okay?
Yes, we can. You are good to go.
Oh, okay, thank you. So I'm going to stop my video because my internet connection is a bit weak. And I'm going to start with the presentation. So as Dr. Wolsky said, I am a PGY2 at the Cleveland Clinic. So this is the paper I'm going to present today. This was published in the International Journal of Gynecological Pathology back in January 2022. It was published by Remy Flipo and colleagues. The name of the talk or the paper is Vulvar Basal Cell Carcinoma, Clinical and Histopathologic Features. Basal cell carcinoma is a well-known entity for us as pathologists because this is the most frequent skin cancer, and there are also well-known risk factors such as UV light exposure. However, this entity is very rare in non-exposed areas such as the vulva, and there is no etiological factors associated with vulvar basal cell carcinoma. Even the FIGO treatment guidelines are not designed for non-metastatic basal cell carcinoma of the vulva, which is the most common presentation of a basal cell carcinoma in this area. This entity, as I said, is very, very rare. It comprises less than 1% of all basal cell carcinomas and is also less than 5% of all vulvar malignancies. His prognostic features are not well recognized or described, and that's why this group decided to investigate and identify both clinical and histologic features of basal cell carcinoma of the vulva that can be related to prognosis. So what they did was they collected multiple patients that had surgery in their institution between January 2000 to December 2019. They had multiple patients, but only around 23 patients had diagnosis of vulvar basal cell carcinoma, and only 19 patients had a complete follow-up information, and also slides available for review. They collected these patients. They were, as I said, 19 in total that met inclusion and exclusion criteria. They performed immunohistochemistry for P16, which was negative in all the patients. And they collected clinical and histologic features that were then compared to outcome in terms of disease-free survival and overall survival. They found that these were the most described clinical features that they found. Patients were in between 54 and 99 years old. The median was 74 years old. The tumor localization was mainly labia majora in almost 70% of the patients. The main symptom was pruritus and also vulvar lump. All the patients received surgery, but only one patient received additional radiotherapy. Regarding to histopathologic features, I'm going to start with this slide because I want to define two things that they use. So they use size of the lesion that was described as the parallel measurement or the measurement parallel to the surface of the epidermis. And they also described thickness, which was measured from the surface of the lesion to the deepest portion of the lesion. The tumor size ranged between 2 and 65 millimeters. 13 cases, which is almost 70% of the patients, had an average size of 19 millimeters. And in the recurrence-free cohort, we have 80% patients who had a tumor size lower or equal to 20 millimeters. They also identified different subtypes and architectural features of these tumors. The nodular subtype was the most common, described in 60% of the cases, and 5 patients had infiltrating BCC. Superficial was only described in 3 patients. The architecture was mainly macronodular in almost 60% of the patients. 5 tumor, which corresponds to 26%, had a trabecular architecture, and only one patient had a micronodular architecture. All the patients had an AGCC score of T1 and 0 and 0, which corresponds to what I said before in the introduction. Most of these cases do not have nodal or distant metastasis. As I said, all the patients received surgery, but interestingly, most of the patients received wide local excision, which was described as tumors that were removed with a margin of more than 3 millimeters. 42% of patients received partial vulvectomy, 5% total vulvectomy, and another 5% radical vulvectomy. The overall survival of these patients ranged between 6 to 132 months, with a median of 36 months. Most of the patients, almost 80%, did not experience recurrence, and for patients, 21% experienced recurrence at 15 to 24 months. These are the Kaplan-Meier curves that they created and reported in the paper. I'm going to start with part C and D because these were found to be or to have statistically significant difference with a p less than 0.05, and this one was more importantly a p less than 0.03. These patients had a size of the tumor that the cutoff that they used was 20 millimeters. So we can see here that the overall survival of the patients who had larger tumors was worse compared to patients who had smaller tumors. So this is the, let's say, low risk group of patients, and this is the high risk group of patients. If we take into account size of the lesion. Margins, as I said, was also important. Patients that had more than 3 millimeter margins had also better prognosis in terms of overall survival again. And patients who had less than 3 millimeters margins had worse prognosis. Also treatment, sickness, they did see two different populations with high risk and low risk. However, I want to emphasize here that the difference was not statistically significant for these two things. And none of them were statistically significant for recurrence-free survival. So finally, they found that type of surgery, size of the tumor, thickness, and the margins were associated with recurrence-free survival. Tumors that were larger than 20 millimeters or thicker than 3 millimeters are more common to recur after surgery, and also these patients had better outcome in terms of overall survival. However, this study faces many limitations. The first one is the number of the patients. They only had 19. It was only a single institution study, so I think it's worth it to include more patients to have a multi-institutional cohort. And also, they didn't say anything about like sun damage. I know this area is not prone to sun exposure, but you can describe if sun damage was present or not. They also mentioned that it could be, or it may be worth it to explore CK7 expression, given the fact that CK7 appears to be expressed in BCCs that appear in non-sun exposed areas. I also think it's very important that they performed P16 immunohistochemistry to rule out like a different entity or a different association, and it was negative. However, I think it could have also been complemented with FISH or FISH for HPV. And otherwise, I think it's important to start to pay attention to these facts, tumor size, thickness or to these features, tumor size, thickness, the margins of the tumor, to have better guidelines for follow-up and for further surgeries in these patients if needed. And that was it for my presentation. I am happy to take any questions, and thank you so much.
That was excellent. Thank you. So I don't see any questions in the Q&A right now. So I'll ask you, Dr. Toro Castano, the straightforward question of what was your biggest takeaway from this paper?
So first of all, this is a very common entity because we all are familiar with basal cell carcinoma. However, we don't think that we can have this disease in the vulva. So the first thing was, okay, this exists in the vulva, and we have to acknowledge that. And second, so what to do in terms of follow-up and treatment for these patients. Nobody knows what to pay attention for and what to take into account. So I think that we as pathologists have to report things such as thickness, size, margins. So those things have to be in our report, and those have to be taken into account by the clinicians and surgeons to follow up on these patients better.
Yeah, I completely agree. This is one of these papers where being aware of this entity in this site, half of it, and that the thickness of the tumor, I believe, is from the most adjacent dermal epidermal junction from the nearest superficial dermal papillae. You know, they mentioned one thing I would have liked to hear more about is they mentioned in the methods that they excluded. It was unclear how many cases of patients who'd had residual gross disease, I believe it was. And I wanted to know more about what do these patients look like who have a BCC with residual gross disease, and know more about the patients who may not have had the negative margins as well. We do have a question now. Thank you. So is there a CAP protocol for vulvar BCC? If not, it may be worth proposing. It's an excellent question. Do you want to take a shot at answering, or?
I think it's not. I think it is not because, yeah, I think it's not a CAP protocol for vulvar BCC.
They don't have a dedicated CAP protocol for vulvar BCC, but in the vulva CAP protocol, it is listed as one of the types of carcinoma. And so that would be the protocol to use. The paper does mention, you know, as this question is also getting at, that perhaps the staging system, right, is not appropriate or not the most appropriate for vulvar basal cell carcinoma.
Yeah, so
I have no
it
doubt
looks like the FIBO guidelines include patients with metastatic disease. So it looks like there is guidelines for metastatic disease, but not non-metastatic disease, which is the most common. Yeah,
get lumped with it. So I think this paper is getting at the need for a better staging and prognostic system for vulvar BCC. Yeah. Okay, we'll move on. It's 10:20. Thank you so much.
Thank you.
So, Dr. Tuma, I believe we have you next if you want to share your screen.
Hello, Dr. Wolsky. Okay, I will share my screen now. One second. Can you see my screen?
Yes, and we can hear you. You're good to go.
Okay. Thank you. Hello, everybody. Thanks for having me here today. My name is Kamille Tuma. I'm a surgical pathologist here in Brazil. And today we'll be talking about the molecular characterization of invasive and in situ squamous neoplasia of the vulva and implications for morphological diagnosis and outcome by Tessier-Cloutier and colleagues. Vulvar carcinoma represents 3 to 5% of all gynecological malignancies. Among them, vulvar squamous cell carcinoma VSCC correspond to 80 to 90% of the cases. However, it's important to mention that there are two main pathways to vulvar squamous cell carcinoma. The first pathway is through HPV infection or HPV associated. It's more common in younger women between 20 to 40 years old. In the microscope, you can see a basaloid and warting morphology, and the main precursor is high-grade squamous intraepithelial lesions, or HSIL. The second pathway, it's not related to HPV, so HPV independent, and it's more common in older women between 6 to 8 years old. In the microscope, we can see a keratinizing morphology, and the main precursor lesion is differentiated vulvar intraepithelial neoplasia, or DVIN. However, in recent years, we see a third pathway, another pathway, that comes from this HPV-independent group with two new precursors. And these precursors are called vulvar acanthosis with altered differentiation, VAD, and differentiated exophytic intraepithelial lesions, DVIL. It's known that these two lesions are very related to varicose carcinoma. Besides morphology, there are another main characteristic that is different between these precursors of the HPV-independent group. That is the mutation for TP53. In differentiation vulvar intraepithelial neoplasia, you have the presence of TP53 mutations, while in these new precursors in varicose carcinoma, you have absence of this mutation. Here in the article, I will show you or exemplify to you some of the entities that we discuss. So the first picture, picture A, we can see an invasive component with a keratinizing morphology. This is more common in the vulvar squamous cell carcinoma HPV independent. On the other hand, in picture C, you can see an invasive component with a much more basaloid morphology. It's much more common in vulvar squamous cell carcinoma HPV associated. In picture B, we can see varicose carcinoma, a neoplasia that's very well differentiated with minimal atypia of the keratinocytes, with expansion of the rete ridges and a broad pushing front of invasion. In picture D, we see the VIN, an in situ precursor of the HPV-independent group that is characterized by basal atypia that's moderate to marked, eosinophilic keratinocytes, and elongation of the rete ridges. This paper has a category called suspicious for the VIN. In this category, the authors put lesions that do not display the classical morphological features for the confident diagnosis for the VIN. So, for example, lesions with inflamed atrophic with mild to moderate basal atypia, or lesions with acanthotic with mild basal atypia. They put in this category. Another precursor is VAD. VAD is an in situ precursor of the HPV-dependent group that's characterized by a triad. We have marked acanthosis and sometimes variable verruciform morphology, loss of the granular layer with superficial epithelial pallor, and multi-layer parakeratosis. In picture F, you can see the DVIL, another in situ precursor of the HPV-independent group. Here you can see an acanthosis and verruciform morphology, absence of conspicuous basal atypia, and abnormalities of the keratinocyte differentiation, such as hyperkeratosis, parakeratosis, hypogranulosis, and dyskeratosis. And finally, HSIL. HSIL is the site precursor of the HPV-associated group, and it's characterized by basically for disorganization, crowding, this basaloid morphology, and hyperchromasia of the cells. So the main object of this paper is to examine the mutational profile of VSCC, focus on the HPV-independent lesions, and uncover any biologic, prognostic, and therapeutic insights for this understudied disease. The authors took patients from the archives of Vancouver General Hospital in priority to HPV-dependent VSCC with associated in situ lesions. There was made a morphological review, and that was characterized in the groups that we already discussed. Immunohistochemistry was made with P16 to discriminate between the HPV associated group to the HPV independent group. And a molecular analysis was made with an NGS panel that target 123 hotspot mutations. Here, we have in the study 40 patients and 75 samples were taken. Was made a morphological review, and in this morphological review, they characterizing the diagnosis seen here, breaking down here. Mutation analysis was made in 38 patients of the HPV that had HPV-independent squamous lesions. It's important to mention that 25 of these patients had matched in situ and invasive components. A mutation analysis was performed in 69 samples in this group. And NGS detected 6 different genes, being TP53 the most common genes. So based on that, the authors divided this group of patients in 2 groups. The first group with TP53 mutations, and the second group without TP53 mutations. Let's start for the first major group. TP53 mutations was found in 58% of the samples. And the co-occurring mutations appeared with PIK3CA, HRAS, PTEN, and MET. P53 was mutated in the majority of the VSCCs, the VIN, and lesions suspicious for the VIN. So the authors conclude that VSCC arising in association with the VIN or lesions suspicious for the VIN are much more likely to harbor TP53 mutations compared to other precursors. In the second group, without TP53 mutations, we have here a much more heterogeneous group. In this group, we have more frequently PIK3CA and HRAS mutations. PIK3CA appear in 29% of the samples, HRAS in 17% of the samples, and both of them in 13% of the samples. Here reside the entities that's verrucous carcinoma, DeVille, VAD. Lesions associated with lichen sclerosus were not P53 mutated. And PTEN was not specific to any molecular group or diagnosis. So the authors conclude that verrucous carcinoma, DeVille, VAD, and associated VSCC were much more commonly mutated for PIK3CA, HRAS, MET, and PTEN when compared to the VIN or lesions suspicious for the VIN and associated VSCC. In 26 patients, the invasive lesion was spared to at least 1 precursor lesion. 7 of these cases showed evidence of molecular progression. Invasive components often gain mutations such as TP53, HRAS, BRAF, and one case had the in situ component with TP53 mutations, but the invasive component, the TP53 mutations, was different from the in situ one. 3 cases had mutations in the in situ component that was not found in the invasive component. 11 cases of lesions suspicious for the VIN adjacent to VSCC were morphologically studied. In these cases, they found 2 scenarios. The first scenario was an inflamed atrophic or normal thickness skin with mild to moderated basal atypia. These cases, all of them, were P53 mutated. The second scenario was acanthotic lesions with mild, bordering on moderate basal atypia. In this scenario, none of the cases were TP53 mutated. However, let's take a look a little bit better in this second scenario. This second scenario, you have one case that did have PIK3CA and PTEN mutations. On morphology, this case was considered as a DVIN. However, its mutational profile fits way better DeVille than DVIN. The other 2 cases did not have any mutations. However, TP53 mutation was found in the adjacent VSCC of these cases. Univariated and multivariated analysis was made, and they found that tumor depth of invasion, perineal invasion, and margin status correlate with worse overall survival while tumor focality, nodal status, and margin status correlated to worse progression-free survival. Here in the side, you can see a Kaplan-Meier analysis that evaluate 4 molecular groups. And what we can see here is that the group with TP53 mutations and PIK3CA mutations combined had a worse overall survival and worse progression-free survival. Here's a summary of all the findings of the paper, then the 4 cases that were evaluated and the molecular findings. To summarize this table, we can show the main mutations in this paper that they found in these HPV-dependent lesions. TP53 mutations was found in the majority of the VSCCs, the VIN, and lesions suspicious for the VIN, while PIK3CA and HRAS was found in the most of verrucous carcinoma, DeVille, and VAD. So the majority of cases of the VIN, they had the same mutation as the invasive counterpart. So the authors suggested that TP53 is could be an early genetic event in the development of HPV-independent VSCC. Basal atypia is the only sensitive morphological feature, so you should consider it even in the absence of acanthosis, parakeratosis, or hyperkeratosis. And based on that, the second scenario, pathologists should not confidently exclude the diagnosis of the VIN in the background of inflammation in the presence of atypia, especially in cases with atrophic or non-acanthotic appearance. In VAD and DeVille lesions, you can see PIK3CA and HRAS mutations more frequent. These lesions can be very difficult, very hard in practical, because they have an overlap of morphological features. So they can be very enigmatic to the practicing pathologist. And clinical outcome for these P53 wild-type in situ lesions deserves for future studies. TP53 mutations was found in progression. 5 of the cases showed additional TP53 mutations, the invasive component. So the authors conclude that the development of multiple structure variations increased the malignant potential of the lesions. In the Kaplan-Meier analysis, one of the groups, the TP53 mutation alone, they were not an independent predictor of outcome. However, as I said before, the combination of TP53 and PIK3CA mutations was a strong predictor of worse outcome. So the study opened up our horizons about these HPV-independent lesions and the possible molecular race. These lesions are very hard, and they explain them very well, the morphological and molecular dilemmas of the VIN, VAD, and DeVille. And they evaluate the impact of clinical and molecular aspects on overall survival and progression-free survival. The limitations is, of course, the number of cases. There are few cases, and if the findings needs to be have reproducibility, it's important to have a larger series. The paper didn't target some mutations that other authors have mentioned in their other authors mentioned, such as CDK, N2A, and others. And the NGSSA did not cover the entire TP53 mutation gene, TP53 gene. So mutations outside of the hotspot were missed. And the number of cases of HPV-associated lesions was very small, so could not compare the two groups. For me, in my practice, I think what are most taken in this article is the morphological spectrum, the variability of the morphological spectrum of the VIN, VAD, and DeVille. That's completely hard, and to be careful in our practice to not miss these lesions. The authors suggest that P16 and P53 should be made in all cases of vulvar squamous carcinoma. And here we can do that. We do basically on cases, but we know that P53 immunohistochemistry can be very hard sometimes. And here in Brazil, at least, we have NGS panels in our lab. However, it's very expensive and it's not accessible to all the patients here. Our public health system doesn't pay for that. So we just do in cases that patients can really pay for the exam. So that's all I have to say about this paper. Thank you very much for your attention.
That was excellent. Can you all hear me?
Yes, I can hear you, Dr. Wolsky.
Okay. Let me start my video. Okay, that was excellent. I think that's a complicated paper and you did a really excellent job of breaking that down, explaining the figures and findings. So thank you. We have not as much time for discussion for yours. So I'm first going to go to a question that we have. So how confidently can one diagnose DeVille and VAD without help of IHC and molecular analysis, considering the morphology is so subtle and overlapping with benign dermatological conditions? I don't know if you want to take a shot at this.
That's a really hard question. Because these lesions, they have many authors classify VAD and DeVille as in the same group of entities, and this is a very hard lesions to diagnose without molecular features, because they are p53 wild type, mainly in this subtle scenario. When they are more exuberant, it's more easier to see, but when it's the scenario of a basal atypia, very minimal basal atypia, or you have minimal abnormalities of the keratinocytes differentiation, it's incredibly hard. So I think molecular, this case would be good to do molecular to see if you find some of these mutations. In morphological, I read a lot of the papers, and all of them had really hard time to diagnosing these lesions. That's in my practical too. So you can complete, Dr. Wolsky.
Yeah, I agree with everything you said. I think that it's not practical for 99.9% of the world to do molecular to diagnose VAD and DeVille. And to be clear, these lesions have evolved in terminology. They have overlapping features, and we have more recent publications, especially by Dr. Carlos Para-Herran, that suggests even using the term, I think it's vulvar acanthotic VIN, so VAVIN. So you can check out that paper. I also wanted to draw your attention, there's a paper by Grace Neville and Dr. Para-Herran that talks about inter-observer variability in making these diagnoses.
Yeah, it's very
so they looked at HSIL and other diagnoses, and I think 8 pathologists reviewed them. And the kappa agreement for HSIL was 0.88, so pretty good. For DeVille, it was 0.61, so not as good. And I'd also point out that I don't think they had the option of choosing no diagnosis, right? When in practice, we are all faced with, is this reactive changes and non-specific changes, or is this VAD and DeVille? And it is challenging. I think it's good if you have the ability to do a P16 and P53 to help rule out other entities, though we know that even the P53 IHC can be challenging, to be sure, right, in the evaluation of DVIN. Okay, we are going to move on to our last presenter. So if you want to stop sharing your screen, Dr. Tuma, thank you so much for presenting that. And Dr. Vemuri, if you're ready, you can share your screen.
Can you see my screen?
Yes, we can share your screen. We can hear you.
Okay, great. My name is Anusha Vemuri, and I am a PGY3 resident at the University of Chicago. I will be presenting a case series and review of the literature of low-grade fibromyxoid sarcoma in the vulva and vagina. It was published this year by Costigan et al. In the American Journal of Surgical Pathology. The authors sought to characterize this entity in the vulva and vagina where it occurs only rarely, These tumors usually arise in the deep soft tissue of the proximal extremities and trunk. The paper reiterates the spectrum of morphologic features, immunoprofile, and molecular genetics associated with this tumor. A differential diagnosis is proposed, and helpful histologic clues and IHC profiles are described to help work up bland myxoid spindle cell neoplasms arising from this location. And lastly, the clinical course is described. This is a brief timeline of how our understanding of LGFMS has evolved. We started in 1987 when Dr. Evans described 2 cases which were brought to his attention after patients presented with METs. The cases had initially been diagnosed as benign, and so the title of his paper reflects his surprise. The deceptively bland tumor had given rise to metastases. He proposed the name low-grade fibromyxoid sarcoma. It was for a while eponymously called Evans tumor. 10 years later, the possibility of another low-grade fibrosarcoma was entertained. It bore a striking resemblance to LGFMS, but contained characteristic large rosette-like structures, hence the descriptive name hyalinizing spindle cell tumor with giant rosettes. A few years later, the idea was revisited. Cases of LGFMS and HSCT were studied to determine their degree of overlap, and the authors concluded that these tumors are one and the same. In 2003, the novel gene fusion was described in 2 cases, and about 10 years ago, MUC4 was shown to be a useful marker in diagnosing LGFMS. And 35 years after Dr. Evans' first introduction of LGFMS, a case series describing this tumor in the vulva and vagina has been published. Materials and methods: 7 cases of vulvovaginal LGFMS seen in the author's diagnostic consultation practice were included. HME and IHC stain slides were reviewed. MUC4 IHC was performed retrospectively in 2 cases, and all other IHC were performed at primary diagnosis. FUS-FISH was performed retrospectively in 6 cases and at diagnosis in 1 case, and EWSR1 FISH was performed in 2 cases, which were negative for a FUS rearrangement. Patients' ages range from 34 to 58 with a mean of 40. 1 case arose from the vagina and the remaining 6 from the vulva. Clinical history was available in 5 of 7 cases. 2 patients presented with a painless vulvar mass, 2 with labial lesions presumed to be cysts, and 1 patient presented with vaginal bleeding. Clinical impressions included deep angiomyxoma, lipoma, fibroma, and Bartholin cyst. Specimens included 1 needle pore biopsy and 6 local excisions. 3 excisions showed positive margins, 2 of which were re-excised with negative margins. Gross features: the tumors range from 1.2 to 8.7 centimeters in size. Grossly, they were well circumscribed, white to yellow in color, and predominantly firm, with areas that were more gelatinous in consistency. The tumor pictured here had central hemorrhage, and none showed necrosis. Microscopic features: all tumors were unencapsulated, a minority were well circumscribed, and most showed a lobulated growth pattern. Most were focally infiltrative, as is seen here with the myxoid component dissecting through adjacent fibrosis. Stroma ranged from predominantly myxoid with fine fibrillary collagen to more fibrous areas with dense stromal collagen. Figure 1E shows fibrous stroma on the left and a zone of infarction in the upper right. Figure 1F shows dense fibrosis and artifactual white spaces between the thick collagen bands, termed stromal cracking. The myxoid areas showed sharp demarcation from the fibrous areas in a majority of cases, which gave the myxoid portions a pooled appearance and resembled craters on the moon. 2 cases had a tigroid appearance with a sheet-like growth pattern. There is a more intimate admixture of the fibrous and myxoid components. And the tumor can entrap adipocytes, as is seen here along the periphery. Tumor cells consisted of spindle to stellate cells arranged in a patternless to storiform to focally fascicular arrangement. The nuclei were uniform in size, plump, spindled to ovoid, with at most mild hyperchromasia. The cytoplasm was indistinct. Mitotic activity was low with less than 1 per 10 high power fields. And overall, the lesions were of low to moderate cellularity. Vasculature in the fibrous areas consisted of small arterioles. Myxoid foci consisted of curvilinear capillaries, which had an arcade or arching appearance. Rare findings included hyalinized vessels seen on the left, entrapped myoid bundles pictured on the right, and extravasated RBCs, which isn't pictured. Each of these findings were seen in 1 case. The authors noted that the collagenous rosettes were not seen in any case, and no tumors showed areas characteristic of sclerosing epithelioid fibrosarcoma. MUC4 was available in 6 of the 7 cases. Of the 6, 5 demonstrated strong and diffuse positivity, and 1 case was negative. EMA was positive in 4 of 6 cases. It showed multifocal to diffuse staining and was weak to moderate in intensity. 2 cases were positive for both EMA and MUC4, and no cases were negative for both EMA and MUC4. MUC4 stains the tumor in a strong and diffuse manner, and there is weak to moderate cytoplasmic staining of EMA. This table highlights additional IHCs provided for consultation. S100, Desmond, SOX10, CD68, and CD34 were negative in the cases in which they were performed. SMA was focally positive in 1 and negative in 2 cases. Algin blue stained the stroma in 1 case, and HMGA2 was performed in 1 case and was negative. +1 rearrangement was detected in 5 of 7 tumors. EWSR1 FISH was performed on the 2 negative tumors and was also negative. Clinical follow-up was available in 5 patients, including the 3 patients with positive margins on initial excision. All patients are alive with no evidence of disease 10 months to 12.5 years after diagnosis. LGFMS, arising in the vulvovaginal region, has similar properties to that arising elsewhere. Although no recurrences or metastases are reported in this series, recurrences of female inguinal LGFMS have been reported as late as 45 years after diagnosis. The authors suggest that the superficial location of this tumor in this region, as well as their smaller size compared to those in deep soft tissue, confers a better prognosis. MUC4 is a highly sensitive stain for this entity, and EMA may be helpful as well. FISH is not always necessary and can be performed in challenging cases. This table includes tumors that have overlapping morphologies with LGFMS. MUC4 is positive only in LGFMS, and EMA is positive in LGFMS and perineurioma, though it has a weaker staining intensity in the former. Sclerosing epithelioid fibrosarcoma is a separate entity that shares immunophenotypic and molecular characteristics with LGFMS. Fortunately, typical SEF is morphologically distinct from LGFMS and contains cords or nests of epithelioid cells embedded in a fibrous stroma. 4B shows classic SEF with the corded pattern seen in figure 4E. A subset have hybrid features of SEF and LGFMS, and these often harbor a FUS-CREB fusion, which is more common in LGFMS. The EWSR1 CREB fusion is more common in SEF. 80% of tumors are MUC4 positive, whereas nearly all LGFMS are positive with MUC4. Neither pure SEF nor mixed tumors have been reported in the vulva or vagina. And lastly, SEF behaves more aggressively, so it's important to identify this component when present. Strengths: this is the first case series describing this rare entity at this location. The authors underscored the importance of having a broad differential and having LGFMS on it, especially because it's the only malignant tumor amongst the top 3 or 4 most likely considered diagnoses in this location with this morphology. They provide a starting guide for which IHCs might be helpful, and they emphasize LGFMS's propensity for late recurrence, so lifelong surveillance is required. Areas for improvement: there was limited data on how these vulvovaginal tumors were staining with stains other than MUC4 and EMA. Stains like CD34, SMA, and Desmond were performed in just 1 or 2 cases each. Labs are more likely to carry these antibodies as opposed to MUC4, so they're more likely to be ordered during the first rounds of stains as a pathologist works a case like this up. These stains are notoriously nonspecific, so a cautionary note not to place too much weight on questionable positivity might be helpful and might nudge an unsuspecting pathologist to keep searching for the right diagnosis. I would additionally add S100 or SOX10 to the IHC panel for entities like myxoid neurofibromas and myoepithelioma, the latter of which can be positive with EMA. And I thought it was interesting that HMGA2 had been ordered in only 1 case. Given the location and infiltrative edges seen in a majority of cases, I would guess deep angiomyxoma was high on the differential. It may be that labs didn't have that stain, so they did the right thing and sent the case out for consultation. And the same would apply for MUC4. It's not one of the more commonly kept stains, so if you only have non-specific stains at your disposal, and the morphology you see does not fit for some of the more common lesions on the differential. I guess instead of trying to make it fit, it's a good idea to send out for a stain or consult a colleague. And this article provides information helpful for making the right diagnosis. As Evan stated in the very first paper, the tumor is deceptively bland, so it's important to keep in mind. There are benign mimics, which have a more established association with this location. So it's important to identify a tumor as a sarcoma if it is one, so the patient receives appropriate treatment and follow-up. And there are a couple of stains and molecular findings that are helpful, but LGFMS is no exception to the basic tenet of pathology that first and foremost, the morphology needs to fit. Thank you.
Excellent. All right. I don't see any questions regarding this article yet. So what was your biggest takeaway, Dr. Vemuri?
The tumor has a wide morphologic spectrum, and there are a decent number of benign mimickers that occur more commonly in this location. So it's important to keep LGFMS in mind.
Right.
Especially, it's an important diagnosis to make because it requires lifelong surveillance.
Yes. So, you know, this is this index report of these tumors in vulva and vagina. And one thing I wanted to bring up is when you and I were discussing this in the practice sessions, we were talking about MUC4, and can we really say that it's specific for this entity, right? And so you were careful to say it's sensitive for the entity. And I talked to some soft tissue colleagues, and my takeaway is that for the soft tissue differential, MUC4 is quite specific. What I'm questioning, and I think they do mention this in the article, is do we really know how MUC4 would stain the low-grade spindle cell lesions that we typically think of in the vulva, such as cellular angiofibroma, angiomyofibroblastoma, and I don't think we have all of that information. I don't see any questions. Yeah, and I think, again, it's important to acknowledge that these ancillary tests aren't necessarily available to everyone in any country. And this is a tumor where the morphology really can be telling and raise a high index of suspicion for this tumor. And so one could mention that in the report, or if you have the option to send out for ancillary testing, you know, one could do that based on the morphology. Any other questions or comments from our panelists or anybody in the audience? Let's see.
I don't have any questions. I just wanted to tell everyone they did a really great job, and I think it was a good diverse set of articles on vulva, which is, you know, not all just squamous cell carcinoma. So thank you all so much.
And please fill out the survey as the audience leaves. There should be a survey available to you, and we really do appreciate if you can fill that out. In the last moments, there is one question that I apologize, I skipped over. It was a follow-up question about what raises, for Dr. Tuma's article, about what raises the flag that this lesion could be a precursor and needs IHC to solve. And so I think, again, we're talking about the DeVille and the VAD lesions. And I would say the unifying, and please jump in, Dr. Benet, Dr. Hageman, if you have more, but the unifying features are that verruciform acanthosis. And so if it's almost starting to make you consider verrucous carcinoma, for example, but it's not reaching that threshold, that would be one situation.
I mean, I find these lesions to be so challenging, and I thought it was interesting that you brought up that inter-observer variability paper, Becca, because like, even in, you know, I don't know about you all, but if people bring these to consensus, sometimes you have 6 people in the room and they're divided into 3 groups on what to call something in the vulva, because you know, some people want to call it definitively, some people want it to be descriptive, and some people think it's more reactive. And I find getting clinical information to be very helpful in these, which I know, you know, like, does the patient have a mass lesion? Has the patient had biopsies before? Sometimes you don't know that, but if you do, sometimes that helps me. But it almost feels like cheating for the question that you asked me. But yeah, I agree with your morphologic triggers for sure.
I think it's absolutely imperative to remind us to get what a speaker who came when I was a resident, and unfortunately I don't recall his name, but he said it's most important stain is the history stain.
And you now with big places and big hospitals, we often don't get that information, but if you can access it, or if you're concerned about it, you can at least put a note that says, you know, if this is a mass lesion, this may not be representative, or, you know, maybe another biopsy if it doesn't go away, stuff like that can be helpful.
Yeah. Okay, I think that's it. We'll just ask again that everyone please fill out the survey and join us again. Contact us if you're interested in presenting, and thank you so much for joining, to everybody.
Yeah, thanks. Good job on your first journal club, Becca.
Excellent job
great.
to the excellent job to the presenters as well, I should say.
And you. All right, bye everyone. See ya.